Today, Thomas van Dam will give us a general insights into our topic of cholera. Thomas is SolidarMed's program manager responsible for Mozambique. He's a medical doctor with a master's degree in public health, and he has significant field experience in conflict and disaster contexts, and will first introduce you to the context of this disease. After Thomas, Barbara Krusban, the country director of SolidarMed in Mozambique, is going deeper into the experiences SolidarMed has made during the latest cholera outbreak. Barbara, who lives in Mozambique for over 30 years, will tell us about the efforts the team in Mozambique has taken to contain the outbreak and bring health services to the people in need. Please, Thomas.
Thank you, Natalie, and good afternoon, everyone. So we start this presentation with some general thematics about cholera, and I will let indeed the floor to Barbara for what we did exactly in Mozambique. So I would like first to start with the first slide about cholera. What is cholera? Because it's something that is not necessarily well known by all of us, especially when living in Europe, for instance. This is a bacterial disease that is being transmitted through contamination of food or water that we do ingest. And the main symptom is massive diarrhea for some patients. Watery diarrhea that we call also rice water stool, as you can see on this image. In some cases, it's so massive that it can kill even an adult in a few hours. And it's also so massive that if you enter a cholera treatment center, as they are in Mozambique, you will certainly find this kind of bed that looks like a table. Actually, it's a bed that has been specifically invented to treat cholera patients, and you do understand, I guess, how it works. Treatment is mainly rehydration. Antibiotic can be used, but if you want to save the life of a patient, it's mainly about rehydration of a cholera patient. So it can be done orally or through intravenous rehydration. And last about this slide, I wanted to show you this picture that I took. It was 13 years ago when I was working as a doctor in a cholera treatment center in Haiti. This is the same child one day after the other. And as you can see, with a rehydration that was intravenous in that case, because it was a severe patient, you change the face and the life basically of this child. So it's very much of rewarding being a doctor in treating cholera, because it's easy to treat with rehydration and you save patient lives easily. Now, why cholera outbreaks occur? So if there is only one thing that I think to remember, it's poverty. Cholera is the disease of poverty. Low access to safe water and basic sanitation is the main factor leading to cholera outbreaks. However, there are some other factors that do even increase the risk of outbreaks. Obviously, conflicts, because all the damage it creates in society, does increase the risk of outbreaks. Also, when there is displacement of population, especially when those people are in camp, like we can see here, with a high number of people and a reduced access to sanitation and water, it's likely that a cholera outbreak can occur. Unplanned urbanization also has been said and to be very much of an environment for cholera outbreaks, and even more when this kind of event happen, an earthquake. Here you find a situation where a cholera outbreak is very likely to happen because of the disruption of access to water and sanitation. But what about climate change? Now it's pretty clear that climate change also increases the risk of cholera outbreaks. And why? Basically, because of those extreme climate events that we see more and more, flooding, droughts, and that those events do basically reduce access to safe water or to sanitation. But also, you might be interested to know that cholera is present in the environment, typically in this kind of setting, and it has been proven that those brackish water, the warming of those water does increase the development of the Vibrio cholera and the risk of transmission to humans. So now, what is the situation globally? what we see is that since 2021, there is a significant increase of notification of cholera globally. Not only the number of outbreaks has increased, but also their size. It's bigger outbreak and more outbreaks. If we look at the map of 2023, we see that the most of the countries that are affected are in Africa, and especially in East Africa, East and South Africa. Looking even more in the details of the data, we see that the country where SolidarMed is working that are highlighted on this table are facing the highest burden of cholera cases, or some of the countries facing the highest burden of cholera cases in 2023 and beginning of 2024. So what should be done to address this situation? There is a global task force on cholera control that is very much linked to the WHO, and that has published some documentation, and notably a global roadmap to 2030. And the objective is a reduction in cholera deaths of 90%. So we don't talk about elimination, actually, we talk about reduction in deaths. And what is most interesting in this document is to look at which sector needs to be addressed to solve those to reduce the number of deaths of cholera. So obviously, water and sanitation is one of the main area to be tackled, but not only surveillance and monitoring, the use of the cholera vaccine, and we'll come back to this after, the strengthening of the healthcare system, and the leadership and coordination. And interestingly, at the center of all of this, the engagement with the community has been said to be key in the fight against cholera, with hygiene promotion measure, with risk reduction measure, all what we did in Mozambique, and that Barbara will explain just after. So quickly, what about cholera vaccine? A short slide about that, because we might believe we have a vaccine, we have a solution. Actually, it's not so straightforward. Yes, the cholera vaccine is effective. It's an oral vaccine, so it's quite logistically quite easy to implement, but it has an efficacy that is not perfect. After 24 months and 2 doses, it's less than 70% efficacy. So this is not a routine vaccination. It has been used essentially in preventive and reactive campaign those last years. On this map, you see those two types of campaigns. Preventive campaign, basically when there is, for instance, a rainy season and we know that there is a cholera outbreak in a certain part of a country, one Ministry of Health might decide to do a preventive campaign before the season to reduce the risk of outbreak. But what is mostly done is reactive campaign. It's done when there are already outbreaks ongoing to control the spread of the Vibrio. And this is this group of organizations that is managing the request of some country for the cholera vaccine. Why? Because there is not enough cholera vaccine for the needs currently. And there is a group that is trying to allocate the best following the request of those countries. But because those vaccines are not enough, now we have promoted, the international community as promoting the use of a scheme of 1 dose instead of 2, which allow to reach a higher number of people, but with an efficacy that go below 50% after 24 months. So here, it's just to explain that, yes, cholera vaccine is good, but it should be complemented with other intervention, especially at community level, because at a standalone intervention, it cannot reach the objective of significant cholera reduction by itself. Last, why should it matter to us? So first, I would say, this is the public health issue. And when I say public health, I think about the discipline of public health and the capacity for us to work at population level when we work on cholera. And this is very fit for an organization like SolidarMed to work on this kind of question, like cholera question. It's also because cholera is preventable and treatable. And it's even maybe a moral question to try to address this issue, as we have all the tools and mechanisms to prevent this disease and to avoid any deaths happening with cholera. Especially also because cholera control intervention can be very cost effective. Vaccination is cost effective, but also some other intervention like we do at community level with the provision of oral rehydration salt for the patient, like hygiene promotion activities, can be very cost effective. Also, cholera disproportionately affects disadvantaged group, and this is probably one more reason for Solidarmed to engage. Cholera outbreaks also are very much ongoing in Solidarmed area of intervention, and because of that, we might have more responsibility to act, at least in some of those countries, because it's happening in front of us. And last, I would like to mention that eliminating cholera is both a humanitarian and development question. It's very much a multi-sectoral approach that appeals to a lot of expertise, definitely including the expertise of Solidarmed. So now I would like to let my colleague Barbara to give more information on what we did exactly in Mozambique. Barbara, the floor is yours.
Yeah, thank you very much, Thomas, for this very nice picture of the situation of cholera in general. And let's now dive into Mozambique. And show them. Okay. So here you see, obviously, on the left-hand side, the map of Mozambique. Please focus on the north, that part in the rectangle. That is where Solidarmed works. And if we go even nearer, you will see the districts where Solidarmed intervened in our last different cholera projects we had. What is important is to understand as well that this area is an area which is very much affected by multiple and ongoing conflicts. The size you see in red, that is roughly the area of Switzerland, just to have an understanding how broad the geographical areas is where we intervene. Yes, Thomas, please. On the top, on the right-hand side, you see the name Fundação Wiwanana. We work in partnership with this foundation, Wiwanana Foundation. It is a national NGO with focus on community health. So you can see that we are serious in walking the path towards localization. All of our last cholera projects, which were financed by SDC, were mainly on response of outbreaks, but now we are shifting more and more to addressing prevention, as Thomas mentioned. Our projects are aligned with the National Cholera Elimination Plan, and we are integrated, is also very important, integrated into the national, provincial, and district coordination structures, as well as the United Nations cluster systems. Okay, so now my next three slides are on the three main areas of intervention of our projects, which is prevention, early detection, and control. So first on prevention. We engage with affected communities in high-risk areas in health promotion activities. How? We are bringing key messages from door to door, engaging with family members, and understanding and addressing their concerns. We are distributing hygiene material, for example, soap and bottles of chlorine-based solutions. And for example, as well, we are supporting radio spots and interactive theater plays. These are very important. Some of you might know the method theater of the oppressed. So we are trying really to be as deeply in the villages and in the system which we find there. Let's go to the second area of intervention, which is the early detection. We strengthen the epidemiological surveillance from the bottom up, meaning from the villages up to the district level and then further on to the provincial level. How? We train community health workers in the recognition of symptoms and in early treatment, for example, with oral rehydration salts, which Thomas mentioned already. We support the testing of feces and water, and we are part of a network to map all the cases. And going to the third area of intervention, which is control. We stop the transmission when cases are detected. How? By proceeding with sensitive disinfection of households and careful follow-up of contacts. You may have heard that I tried to stress these two words, sensitive and careful, because we need to avoid stigmatization and the possible rejection of our interventions. Coming now to the last slide with some achievements. They are from our most recent short-term cholera project, which was a preparedness project from January to March 2024. As you can see, we reached 62 high-risk communities in the 5 districts of Cabo Delgado province. In 5 districts, we worked on the training for 100 healthcare workers on hygiene promotion and community interventions. The other numbers I won't mention. You can see them. You can go through it yourself. But I would like to focus on an interesting aspect which shows how deep the community engagement must go. We can look here at the radio debates and the plays in the communities or the spots. Makua is the most widely spoken language in northern Mozambique, also in Cabo Delgado. But Makua is not equal Makua. You can imagine that in every district nearly, there is a different form of Makua. So you have to be very, very careful how you promote these plays and the radio debates and the spots, because we have to be extremely careful not to increase the feeling of marginalization in this conflict-ridden area. So that was my part of the presentation. We can now go to the last slide, which is about the questions.
Thank you very much, Barbara and Thomas, for your expert insights. We do have time for a few questions. I have not gotten any questions in the F&A section yet. You are free to share your questions, or you can unmute your microphone and just post them as you would like. Barbara, we have a question for you. You mentioned radio as a tool to address the community. How about podcasts?
Yeah, that is a very good point, but it's probably too early for many of our communities. It would need an additional input with equipment. So we could do it, yes, but we would have to bring them the equipment, which makes it then possible to interact or to listen to these podcasts. But I think we always need to be very open to modernizing what we are doing. So I think it would be a lovely method, but probably a little bit too early for the time being. In the in the bigger communities or in district capitals, there you could do it, yes, for sure.
I just got a note that you cannot unmute your microphone, so please put your questions down in the F&A section, please. So here we have another question. What is the difference between a small outbreak and a big outbreak? Probably a question for you, Thomas.
There is no definition of what would be a small and a big outbreak. And an outbreak is as soon as there is one case of cholera, it's considered as an outbreak, because it's so much of a contagious disease that a first cases of cholera is considered already an outbreak. But there are smaller and bigger. And what makes the difference usually is that it's where it happens. If it happens in an environment, typically urban, or a setting like a camp of displaced people or refugees, where there is high concentration of people with low access of sanitation, and especially if there is no immunity in this population, no vaccination, or no recent contact with cholera, you are likely to have a big outbreak. And historically, if we look at what happened as the biggest outbreak, some of them was, for instance, at the time it was Zaire, in DRC, after the genocide in Rwanda, all this displacement of people people in Congo, in Zaire at that time, on this big camp. It has been historically one of the biggest cholera outbreaks because of those reasons. More recently, but time where I was working, I show you a picture of Haiti after the earthquake of 2010. These countries has not known cholera during decades, or during all its history, actually, as much as a memory of what we have. And it was a population very naive from cholera, and it led to a big outbreak. In Mozambique, it's slightly different. In Mozambique, cholera is endemic. So we have outbreak. They are big in terms of numbers, but they do not reach the same level because there is kind of an immunity, and it happens more in an open setting in villages, in rural areas. But still, it does spread a lot, and it spread much more. Currently, it's the biggest outbreak in Mozambique since more than 20 years.
Thank you, Thomas. I think another question for you, Barbara. Why is it so important to work with the local communities?
As they say themselves in Mozambique, that is a standard phrase, nothing for the communities without the communities. It is for them, it has to be the way that is the most sustainable for them. Without them, you won't reach anything. Without them, I saw it once, I think that was 4 years ago, after Cyclone Kenneth, there was a vaccination campaign. If you don't prepare the communities, they won't even accept the vaccinations, the vaccines. They won't be there. It was the same time as Ramadan. So they wouldn't accept anything during the day. So we had to shift everything for the time when it's then available. So you can't just push something through. You have to really understand who you are working for, how you can do it the best, so that you can reach the best result.
Thank you very much. We have another question maybe to both of you. How to deal with outbreaks when they overlap, for example, malaria and cholera?
All right. Should I start?
Yeah, you can. Yeah, please.
Actually, they are ongoing in Mozambique, and there is malaria. It's two of the most public health issues that are affecting the populations that we serve. And we have other projects, for instance, working on the pediatric emergency care that is trying to address also the problematic of malaria. There are some commonalities, and when we go to the population and when we make community activities, we try not to be vertical, and we try to take this opportunity to address some other issues. So we might do some intervention in the community. The message are not the same because it's two different diseases. The way to be contaminated are drastically different, but we can optimize the resources that we have to try to address those issues at the same time. But they are very different, and the way they should be prevented are very different also, and we try to still make this difference. And so reducing the risk of cholera does not necessarily mean reducing the risk of malaria.
Yeah. But if I may, just adding, the community health workers, they have different packages. So they are not only trained, now they were retrained by us in cholera prevention, but they also have HIV, mother and childhood packages and malaria packages. And some things do overlap. For example, having a good sanitation, you fight the reproduction of the mosquitoes, and you might then even decrease the risk of contamination with cholera in these stagnating waters, etc. So it is, as Thomas said, it is something which has to go hand in hand with the other issues as well. You can't just address something just as such.
Thank you very much. Thomas, could you maybe go to the last slide? We are already at the end of our brief lunch session. Thank you very much for joining, for your attention. You will receive a follow-up email with links relevant to this topic where you can have some readings afterwards. And now we wish you all a pleasant afternoon and hope to see you again on our next webinar, probably at the end of the year. Thank you very much. Goodbye, everybody.
Thank you, Nathalie. Bye. Thank you, Barbara.
Thank you all. Bye. Thanks.